I'm back again. We talked about pulmonary infections the other day, and now what we'll do is we're going to talk about infectious diseases overview of what could be on your boards. So we're going to have, I believe, the next hour and a half or so to go through all this. So um, you don't need to see that picture anymore. I have absolutely no relevant financial disclosures to discuss, and there'll be no off-label or investigational uses throughout this talk and the next talk. Here's our review where we'll go through a bunch of bacterial diseases, including STIs or STDs, as well as other board eligible bacterial diseases, as well as fungal diseases. And then we'll quickly review some infectious syndromes, osteomyelitis, septic arthritis, MRSA, sepsis, and SIRS throughout this talk. So let's start with bacterial disease. One that's a board favorite and one that we are thankfully seeing less and less of throughout the United States and worldwide, although in certain countries, particularly in the developing parts of the world, we are still seeing high rates of acute rheumatic fever. But in the US, it's significantly, drastically has decreased, thankfully. But how does this occur? Where in the question stem? What are you looking for? Is you'll have somebody that comes in with a history of acute pharyngitis or recent pharyngitis, so sore throat that went untreated, and it was group A strep. So this is what when we talk about strep throat, and this is why we test for it, and this is why this is the one time where we do actually treat a sore throat with antibiotics, as we want to target this group A strep. However, in those who let it run its course and never got antibiotics, a couple weeks after the strep throat has resolved, your body makes antibodies, so your immune system starts to form against this group A strep. And unfortunately, there's some what we call molecular mimicry. And those antibodies, as they're thinking they're attacking the group A strep or strep pyogenes, actually starts to attack certain parts of your body. So it becomes almost an autoimmune type disorder where it damages the lining of your heart valves, especially, can damage your joints, subcutaneous tissue, and as well as go into the brain and cause CNS issues. So you see this type of syndrome that occurs where somebody will come in with heart valve dysfunction, joint swelling, nodules in the skin, and oftentimes some CNS abnormalities, which we'll talk about. You see it most commonly in children. And as I mentioned earlier, we still see high rates of this in certain developing countries, although thankfully we're seeing much less of this in the United States. So in your question stem, a lot of times this will be, they'll say either a child or somebody from outside of the United States. That right there is a little bit of a clue or tip off of rheumatic fever. There's something called the Jones criteria. This is different than the modified Duke criteria for endocarditis. This is Jones criteria for acute rheumatic fever. And there's major and minor criteria. So the major, remember, as I mentioned, what do those antibodies attack? We talked about the heart, so you could see carditis or valvulitis. We talked about the joints, so arthritis. Something called chorea, which is, you'll hear something called Sydenham's chorea. So what happens is you get this uncontrollable arm flapping. They call it Sydenham's chorea or Sydenham's dance, erythema marginatum, and subcutaneous nodules, because again, it does attack some of the subcutaneous tissue. Minor criteria are fevers, joint pains, elevated inflammatory markers, ESR, CRP, and prolonged P to R interval. The diagnosis requires either 2 major or 1 major plus 2 minor or more. And have a prior or recent infection of group A strep that was untreated. Treatment for acute rheumatic fever is actually anti-inflammatories, aspirins, high dose, corticosteroids. We often will give a single dose of penicillin because again, we want to target that group A streptococci or strep pyogenes. And it may require heart valve replacement in the future due to the underlying damage to a heart valve. How do we prevent this? So if somebody has, once they get acute rheumatic fever, it can recur after you give them the penicillin, after you give them the anti-inflammatories, it can recur. So what we end up doing is, as I mentioned, usually this occurs in children. So we'll place that person or that patient on daily oral penicillin or monthly intramuscular penicillin until the age of 21. We're going to shift gears here a bit. I apologize. Let me go back. we're going to shift gears completely more towards sexually transmitted infections. These are board favorites. You need to know this. You will see this in your practice, regardless of what area you're in, either community, either internal medicine, or even in subspecialties. So chlamydia, this is a map of chlamydia in the United States. And I don't know what's going on in Alaska and the Southeast United States, but definitely some high rates of chlamydia there. What you'll often see is a purulent cervicitis, and it can also cause inflammation, conjunctivitis as well. The cause of chlamydia is chlamydia trachomatis. Again, it's the leading infectious cause of blindness worldwide. This is why infants at delivery, or newborns at delivery, will get actually an antibiotic ointment to their eyes to prevent ocular chlamydia and thankfully prevent blindness. It's the number one, excuse me, it's the number one bacterial sexually transmitted infection in the world, as it can cause genital infections. And the reason why that is it's often spread asymptomatically. So if you're feeling great, you're not having any purulent discharge from the vaginal or urethral regions, you're likely not going to go see the doctor and say, hey, I think I have syphilis because I feel great. So we actually see around 100 million new cases per year. And the main concern is actually primarily we see are some of the long-term effects in females are involuntary infertility and ectopic pregnancy. So that's why it's important to screen your patients for chlamydia, treat them as well as their partners, as underlying chlamydia infection can lead to these fertility problems in females. Transmission during vaginal delivery, as we mentioned, can be transmitted. It can lead to neonatal conjunctivitis as well as pneumonia. How do we diagnose chlamydia? We have PCR testing or nucleic acid amplification tests. They'll call them NAT or NAAT, but it's all PCR testing of first catch or first void urine in men. You can also do that in females as well, but there's also vaginal swab testing that we would do of the cervix, oftentimes during a pap smear vaginal examination. Treatment for urogenital infection for chlamydia is a one-time dose of azithromycin, so a 1 gram dose, which is a very large dose to take, or doxycycline, 100 milligrams twice a day, but for 7 days. But I star this here, I would bold it too. You also have to treat the sexual partner or partners and if you don't, and they, even though you treat your patient, they can get easily reinfected. And that is the most common cause of reinfection, is not treating the sexual partner. How do we prevent it? Screening all high-risk men and women, all women who are sexually active until the age of 25 or under annually, and with each pregnancy.